Going on to our next speaker is Dr. POOJA KHAMAR, a leading young light of the NN Group of Hospital, Consultant Cataract and Refractive Services, with innumerable awards and accolades to her credit at such a young age. And she is going to take on a very important topic, ocular surface and its impact on patients undergoing cataract surgery. On to you, Dr. POOJA.
Thank you, ma'am. And I would like to thank you and the entire team for having me here. At the outset, I have no financial disclosures on whatever I'm going to be talking about in this presentation. So let me start with this case, a 78-year-old male patient who came in for a cataract surgery for left eye. His other eye was operated, pseudophakic operated elsewhere. He showed a -3 diopter of sphere improving to 618 and had NS3 grading on slit lamp evaluation. When we did his IOL power biometry, we found that the only thing which was not matching, that he showed up an astigmatism of 4.59 diopters, which was like something not matching because the other eye had a monofocal lens, non-toric. And so we decided to repeat the scan after 3 days. And when we repeated the scan after 3 days, then we saw that, the astigmatism from my 4.59 has come down to 1.84. So what was really happening here? Why was there such a big, huge change in just 3 days? What we retrospectively found was that the patient had dry eyes, and on top of that, patient had undergone GAT. And after that, we had done the biometry, and that is why there was such a gross difference, which was, which could have led to this issue of high astigmatism. And we would have probably, if not looked into detail, we would have probably put a toric IOL for this patient and landed up into a refractive surprise. So these are the conditions, it's not just a preoperative ocular surface issue which we are dealing with, but the cataract surgery can also lead to post-operative ocular surface changes, which can make patients' life miserable, and also unhappy patient post-refractive surgery. So what we have to deal here is we have to deal with preoperative, intraoperative, post-operative, and also study the long-term impact. So I would start from the preoperative impact, which already Himanshu sir has given a beautiful talk on corneal topography. And on and off multiple times, the role of corneal topography and ocular surface issues have been dealt with. So we have to be very much careful. But when we are doing the topography, what is the ocular surface condition of the patient? If the patient has dry eye, then we have to treat the dry eye or ocular surface condition and then do a corneal topography for a reliable result. The second thing, we had a wonderful discussion about the newer generation microscope for cataract surgeries, where we said, okay, it's a phenomenal thing. But if the preoperatively the MGD has been missed, or if it has not been picked up correctly, then whichever good microscope you have, intraoperatively this undiagnosed MGD can have a lot of debris on the ocular surface, which can impact, like you can see here, which can impact the visibility during the surgery, and it might not have a very good outcome. So that is also very important to deal with a preoperative dry eye to avoid intraoperative issues also. Post-operatively, let's see this case. This is a patient, normal corneal findings, grade 3 cataract in left eye, again, normal fundus examination. Epithelial thickness was normal, tear film metrics. We went ahead and put a multifocal IOL in this patient, both the patients. If you can see, both are well-centered multifocal IOLs. But post-operatively, one patient was happy with 6.6 and 6, no complaints. But second patient was extremely unhappy, 6.6 and 6, but persistent complaints of post-operative glare, which was not resolving with any of the treatment. Also, we gave patient 6 months for the neuroadaptation, but it did not improve. So what we did, what actually happened here, we retrospectively went back, we do ocular optical quality analysis system for all the patients undergoing premium IOL surgery, and we found that the second patient who was unhappy had preoperatively a poor tear film to begin with. Even though the dry eye tear film metrics were normal, but the tear film quality was poor, and that just exaggerated post-surgery, and that's what made the patient unhappy. And you can see here also that this is a vision breakup time. At just 5 seconds, patient's visual quality is extremely dropping, and after the blink, it's again improving. So that was explaining why the patient had consistent glare post-surgery. So as it was a gross and a exaggerated response, we did the vector pulsation therapy for this patient, and post-surgery you can see how the vision breakup time and the quality of vision for this patient has improved. Again, highlighting the point and the importance of optical quality, which we should check before surgery. Now, Mahipal sir and Rohit sir have already spoken about the OCT-based topographers. So I just want to give a small example here about the role of epithelial mapping, which in cataract surgery. It's still emerging, but I'm sure that is going to be a future, because as we are emerging a lot into premium IOLs, we would have to look at this small changes as well. So let's again, normal topography, we went ahead and did a cataract surgery for the patient, but one patient had a good outcome and the second patient had a poor visual outcome. So what was happening here? Why did both the patients with normal topography had different outcomes? So we went and saw that, the lower and higher order aberrations for the cornea were absolutely normal. No change in coma, spherical comas were also within normal limits. But when we dug deeper, we found that the first patient's epithelium was normal with any epithelial aberrations present, but the second patient had abnormal epithelium with, if you can see here, there are epithelial aberrations present with higher coma in just the epithelium and not the cornea. And we did a cataract surgery for the patient, and post-operatively, the first patient had again normal outcome, but the second patient's aberrations had just gone worse because the epithelium remodeling was not optimal. The wound healing was not optimal, and that's why the post-operatively the epithelial remodeling was not accurate, and the aberrations just went higher, and that's what was making the patient unhappy post-surgery. So right now we are just looking at, if poor meibography, unhealthy ocular surface, we don't do, it might be leading to unreliable, steep or flat K values and poor quality of vision post-refractive surgery. But what we'll have to look further also is the irregular epithelium for these patients, because that is also a point to where we are seeing, an unhealthy ocular surface, because an unhealthy ocular surface or epithelium can lead to a lot of glare halos post surgery. So right now what we see is we just see the corneal aberrations, the anterior, posterior, and the total, and decide whether to do a premium IOL or not. But of course, in future, we will have to use the OCT-based topographer as already highlighted, consider the epithelium, and then decide whether to do a premium IOL for these patients or not, or whether to treat the patients or not. Long-term problems, yes, there are long-term impacts. There have been various reports that if you don't treat the dry eye or ocular surface conditions at the right time, it can lead to depression and anxiety for these patients rather than the patients who do not have any complaint. We do have current modalities, but sometimes it does not work. We have to look further. So role of cyclosporin, it's just not for dry eyes or refractive surgery. It's emerging in after cataract surgery as well. So if you feel that patients have ocular surface issues, then you can definitely give cyclosporin for these patients for at least 3 to 6 months post-surgery for an optimal outcome. What we do here is, if preoperatively we find that the patient has ocular surface issues, then we treat the patient aggressively, wait for 4 to 6 weeks, and then take the patient up for surgery for optimal outcomes. If it's on the higher side, we do one of the newer treatment modalities like vector pulsation therapy or intense pulse light therapy, in addition to the conventional management to help the patient overcome and have an optimal outcome post surgery. So do we need all the tests for all the patients? Of course, new patients do need a detailed history, T-bud and eyelid examination. But if you feel that patients are at risk, then add a questionnaire, grade the staging, do tear film meniscus and breakup time, meibum expression testing, and if it's high risk or uncontrolled, do add a meibography also for this patient. What we have started doing and what would be the future is point of care diagnostic kit. Now, a lot of times, and this is just a ELISA based kit, it's just like your glucometer kit where you can measure the tear markers in your clinic. You don't need to go to a lab. But you can just have a Shermer strip in your kit and measure the tear markers. Why would you need it? As I said, it's just like your glucometer kit. Now, there are a lot of patients who post-surgery complain of chronic itching, chubta hai, chala nahi ja raha hai, whatever treatment you give, it doesn't go off. A lot of discomfort, pain without stain, inflammation, which leads to poor wound healing, irregular epithelium, and which might lead to poor optical quality. And if you have done a toric IOL for this patient, it might land up in a refractive surprise or a poor quality of vision or regression as well. So these are the patients whom we are dealing with. They have a lot of nociception in the eye, a lot of abnormal markers in the eye. So that is why if we can measure it with this diagnostic kit, we can customize the treatment, because not everyone will need a cyclosporin or a tab doxy or a steroid. So if or a vector
1 minute remaining.
Yes, thank you. So if you have a tear diagnostic test in your clinic, we can measure the markers which are abnormal, customize the treatment for this patient for an optimal outcome. I would like to thank my entire team back at Narayan Netralaya for this years of work, which I'm presenting today in front of all of you. Thank you.
Thank you, Pooja. That was a very interesting talk. As always, all the information was there. But I think one tip we take from here on is that before we do a biometry for our patients, probably we should not do any other contact procedure before that, so that we are able to better assess the thing, because these itself could trigger off an irregular Maya. So what would you tell your technician, Pooja, to look for when we are doing the examination, a biometry, and the other things related to cataract procedures?
So, ma'am, one of the most important thing when you're doing a biometry or you're doing your IL master or anything, always do it first. It should not be a test also where, like, even if you have done a dry eye evaluation, like Shermer's test, it would alter the results when you're doing a biometry. So if your patient has cataract and is planning to undergo cataract investigations, then that should be the test which we do first always. And whenever they are doing the scan, they have to look at the position, the quality of the Myers which they are getting, and the centration, the red dot light, whether it's point or scattered, and that's how we we train our technicians to do that. And if they find any abnormality, they have to come and tell us right away, because a lot of times if they don't tell us or they don't report back to you, then it can be a problem.
Ma'am, I wanted to ask one question. Dr. Pooja, what is your take on the role of chloroquine eye drops on management of dry eye?
Sir, personally, we have used chloroquine eye drops and trehalose based eye drops and cyclosporin as well. What we found was that the best drop to use would be cyclosporin or trehalose, because chloroquine is still not accepted extremely well for the patients. The compliance is poor, there's a lot of stinging, and the improvement is not as good as what you find with cyclosporin or trehalose. So
I think adding to what Pooja said, even that fishtail kind of appearance on the those dots on the optical biometry, and also if your standard deviation is also way off, besides the irregular margin, that is also an indicator to consider dry eye. I wanted to ask Dr. Nitin this question, and also Dr. Rohit to add to it. What would you, in the ocular surface disease like a dry eye status, nothing more complex, for your cataract surgery patients, what would be the steroid regime, the NSAID regime, or the lubricant regime would you ask in your practice, Dr. Nitin?
So, just like Pooja said, we follow the same regimen. Basically, the first and the foremost thing is, before any patient undergoes any test of any other sorts, we see to it that at least the keratometry is taken, because that is something which makes a lot of difference. So even before any eye drops are instilled, any dilatation is done. Again, when you ask what you tell the technician, one other important point I would like to make here is that also look for excessive meibomian secretion. Sometimes you have excessive meibomian secretions on the cornea, and you can get way off readings on your keratometry. Regarding the regimen post-op, well, a good lubricant right from the beginning, along with cyclosporin, is what we follow. The steroids, we normally start with prednisolone right from the post-operative, in the first day post-operative. And the steroids, we would not change the normal regimen even for a dry eye patient, unless we find that there is no improvement in the dry eye scores, in spite of having the lubricants, trehalose-based lubricant and cyclosporin. Then we would, after tapering the prednisolone, then probably add a surface-acting steroid like a fluoromethalone or a loteprednol for the next month or so.
Dr. Rohit, your thoughts?
Ma'am, what we do is we track them. We use an algorithmic approach when you're using a lubricant. For example, if the patient has a predominantly evaporative-based dry eye, and if the T-BUT is less than 5, then with a lot of OSDI, and OSDI also really helps because it tells you that there's a lot of inflammation. These patients are the ones who would, and you see changes on the lids. you see a lot of telangiectasias, capped glands, and these sort of stuff. I would prefer them a cyclosporin to start very early, along with the steroids, whatever you use, because when you actually taper the steroid, the cyclosporin would have started working. And these patients, if they have a lot of ocular staining, if you have SPKs or those kind of staining, and less than 5 is pretty not very good. So these would do very with trehalose with sodium hyaluronate based drops or hyaluronate based drops. But if the patient has a TBUT more than 5 and then they are relatively not as symptomatic as per the OSDI and the no lid changes as such, then you can look at, and especially if you're used multifocal lenses, if you're using a sodium hyaluronate based drops, they would experience more scatter. These are all highly viscous. So you would use osmoprotectant kind of drops. Anything you use other than hyaluronate would be osmoprotectant because there's a lot of osmolality changes in your tear film, especially after you use betadine and a lot of paracaine during your topical phaco. A lot of topical phacos would change a lot of osmolality, especially the pH. So these would benefit from an osmoprotectant drops of whatever whatever is available now. So and steroids would not really change much, but now they have options of iLight, EI, and also LipiFlow, even preoperatively and postoperatively. And these are all, especially postoperatively, because the iLight and EI does not really involve any pressure on the eyes. Still, I would think that you can consider this at this point of time. So you can triage them according to the symptoms, the signs, the changes on the lids, especially if they have a lot of lid changes. Those people are driven by MMP9 activities. And these people, you have to start them on cyclosporin because and these with the short course of ointment, of course. But the lid changes are a significant indication of an MMP9 activities, and cyclosporin works very well.
Namrata, Dr. Namrata, what would you talk about non-steroidal anti-inflammatory? How long would you use this in these mild dry eye patients?
No, I don't think I would use non-steroidal anti-inflammatory drops at all in these kind of patients, because for one, that NSAIDs as such are known to cause corneal melts, and two, they do have some effect also on increasing the dryness. So I think as soon as we have a patient of ocular surface disease, non-steroidal anti-inflammatory drugs is a no-no for them.
Thank you, Dr. Namrata. I think it's a wonderful talk, Pooja, and great discussions. Unless Anaga or Satyajit want to add anything.
I have one question to all the panelists.
Yes.
Now that we are looking at so many additions that, what all of us are doing in the cataract workup, like it's not just biometry, like optical biometry, we are adding dry eye workup, we are adding OCT, then we'll be adding topography and tomography. So what is the routine charges? This is off the this thing. What are the routine charges of a cataract workup for a toric IOL patient, for example? Do you charge for everything, or it is just a...
No, we don't charge for everything separately. We don't.
So it's
this
a
is all
package.
free of cost, right?
Yeah.
Huh?
And Anaga, we don't charge for anything, Anaga.
So you cannot, I don't think you can make money on that in your new hospital, Anaga. It just adds to the quality of your practice by diagnosing all those issues and treating them along with, I think.
But one thing is definitely there, Chitra, it happens with refractive patients more frequently. They'll get all the tests done from you and then, get operated elsewhere. So I think some charges you should, take beforehand only before just taking OPD consultation charges.
So we have a package.
We have a
workup charge.
We have a package of 4,500. We call it as pre-cataract workup, and that's the IOL master. Plus we have a specular, and plus we have an OCT. So these three things we charge 4,500, and OSA, if it has to be done, it will be charged separate.
Yeah, I think that makes sense. Maybe we'll have to get
because what Namrata is saying is very correct, because people take because you give them, there are some hospitals who don't give the investigation, but obviously if you give all the investigation, quite often they go to some other place where they don't even have an IOL master 700. So I have had 1 or 2 practices referring the patients to me, not referring to me, but saying the patient, "Aap wahan kara lo, IOL master 700 humne kar diya, wo leke chale gaye," and they got the surgery done at the other place. So there are people who are smart enough. So you need to charge because you have already paid for a huge sum for getting a higher degree of.
We in Patna charge 2,500 for all the things that Maipal sir has said.
Yeah, so it
that's
depends.
the
You
aim.
need to charge something. That's what I'm saying.
Yeah.